First of our sessions this morning is a workshop entitled Health in a Time of Change. And what is the role for consumer and community in a time of change in Australian health policy and services? I'm very pleased to introduce our panel members for this first session. And instead of reading long bios about them all, in your packs on your tables you will find the bios of them all. So I'll just do their brief title introductions and then we can get underway. They'll speak for between 10 and 15 minutes. If we're staying to time, and we might have a chance to get questions after each of the individual speakers. If not, then we'll just wait till the end and we'll have a big question and answer session at the end of all the talks. So we have Sue Dunlevy, who is the National Health Editor for News Limited. This end, Michael Moore, Adjunct Professor Michael Moore, who's the CEO of the Public Health Association of Australia. Dr. Di O'Halloran, Chair of the Western Sydney Medicare Local. Noni, Bourke, Quality Manager for Peninsula Health in Victoria, and Laura Elkin, the Aboriginal Advocacy Manager for Health Consumers WA. So can I invite Sue to kick us off? Thank you.
I want to start my talk today with the tale of two relatives, both of them women in their 70s, both of them privately insured. The first relative was diagnosed with early-stage bowel cancer and needed surgery to remove part of her bowel. She decided instead of using her private health insurance, she'd exercise her right to use the public hospital system. She was admitted promptly for the surgery. It was successful. All her follow-up treatment has been through the public system and it cost her nothing. I suspect if it had been a hip replacement or cataract surgery that she needed, she may have had to wait for 12 months or more, and it may not have been quite as pleasant an experience. The second relative had arteriosclerosis and needed regular treatment to balloon open her arteries. She later developed pancreatitis. She believed, since she'd paid health insurance premiums all her life, she should use her private health insurance. At times that proved difficult because she was so sick the private hospital she wanted to use wouldn't take her in, as often happens to geriatric patients who need a long stay in hospital. Worse still, even though she was an age pensioner, her many specialists charged her hefty out-of-pocket costs, totalling tens of thousands of dollars that weren't covered by either Medicare or her private insurance. She was forced to borrow money from her relatives to pay her bills. I use these two examples because they encapsulate some of the absurdity in our current health system, a hybrid of Britain's NHS and a heavily taxpayer-subsidised private health insurance system. This strange, often inefficient system of healthcare has evolved because of an ongoing ideological war between our two major political parties. Former Prime Minister Paul Keating once said, "If you change the government, you change the country." Well, that statement is certainly true when it comes to health policy. For the last 40 years, every time the government of this country has changed, health policy has changed. As I mentioned before, this political battle over health has been about ideology, whether we should have a universal publicly funded health system or a privately run system. Labor believes in a public system, the Coalition believes a private system is more efficient. Neither side of politics has won this debate, and that's why we have our unique blend of both systems. This ideological war over health began in 1975 when Labor introduced a universal public health insurance system called Medibank. A year later, the newly elected Liberal government tried to undo it. In 1983, the Hawke government reintroduced Medibank, calling it Medicare. The 13-year survival of the Hawke government is the reason we still have a universal public health system. In that time, it became embedded, the medical profession was forced to accept it, and it became very popular. In fact, it became so popular, it threatened the survival of private health insurance, as people opted to rely solely on Medicare for their health needs. Enter John Howard with a new tax rebate for people who took out private health insurance and tax penalties forcing higher income earners to take out the product. The proportion of Australians insured rose from around 30% to close to 50% today. Fast forward to the 2007 election, where Labor, which would get rid of private health insurance if it could, had to settle for tweaking it. To rein in the $5 billion a year spent on private insurance subsidies, Kevin Rudd and Julia Gillard introduced a means test. They also poured billions more into the public health system. But waiting times for elective surgery rose in most states. Labor's $1 billion e-health system is still not being used by doctors, patients or hospitals, and its telehealth initiative to solve the bush health crisis is massively underperforming. With the 2013 election, health policy has made another ideological shift. In the tit-for-tat ideological war that passes for health policy, the Coalition has pledged to remove Labor's means test on the private health insurance rebate when they've got enough money in the budget to do it. The Coalition claims spending on Medicare is unsustainable and has introduced a controversial $7 Medicare co-payment to bring it under control. It's also made large cuts to public hospital spending, and the government is talking about expanding the role of its favoured private insurers into the primary healthcare space. The battle of health ideologies in this country is a bit like those cow jokes that explain political systems. You know how they go. Feudalism is a system where you have 2 cows and the Lord takes all your milk. Communism is a system where you have 2 cows and your neighbours take all your milk. In Australia, private health insurance is a system where you have 2 cows. The government subsidises your barn, feed and milking machine and introduces tax penalties that force the public to buy your milk. The milk's very expensive, and even though the cartons claim they contain a litre of liquid, when you go to use it, there's not enough to cover your cereal or bake your custard. Conversely, Medicare is a system where you have 2 cows. Your veterinary pills are paid for by the government. However, there's not enough money to cover all the milking machines required, so the cows have to wait in long lines to get milked. Some of them give birth to their babies before they reach the safety of the barn. Others have udders so swollen with milk they get sick and die before they reach the milking shed. At first, the government regulates what you can feed your cows and when you can milk them. At times, it refuses to pay you for milking, and your access to milk and the milking sheds become a lottery. In truth, we're stuck with our hybrid health system. Medicare can never afford to take on the privately insured patients. 60% of elective surgery in this country is now carried out in the private sector. But however much they may want to fully privatise the system, no Liberal government can argue for it because Medicare's universality is sacred to the Australian voter. Is it any wonder in this policy environment of constant policy change that health has risen to the top of the list of issues that most concern voters, with a news poll in March showing 81% of voters ranked it as a chief concern? The reason health ranks so highly as a political issue is that these ideological battles over health policy affect people's access to healthcare in the real world. The Abbott government claims the changes it has made are necessary to ensure Medicare is sustainable into the future. It claims annual Medicare costs have risen from around $8 billion a decade ago to $20 billion, an increase of 124%. But when you look at it another way, our health bill still only accounts for around 9% of our GDP, less than the OECD average, and well short of the amount that's spent in the United States. In fact, health spending has actually gone down as a proportion of the federal budget, from 18% in 2006-07 to 16% this year. When you look at the cost of private health insurance subsidies, they've risen twice as fast as Medicare, by 300% in the same period, from $2 billion to $6 billion. Ideology aside, for most healthy people, the new $7 charges won't be a huge burden. The University of Sydney's Beach analysis predicts a family of 4 is looking at an extra $184 a year. An older couple on pensions would pay $199 more a year. And Peter Dutton rightly points out that we've had no objection to paying a co-payment for medicines for decades. The problem with ideology, however, is that what works in general rarely ever works in the particular, and that's especially so in health policy. The $7 fee will be a huge burden to the chronically ill, those with cancer, diabetes, multiple sclerosis and other diseases who already have large out-of-pocket expenses. At the same time as they face paying more for the many visits they make to medical professionals, the government is cutting the Medicare safety net that helps reduce their out-of-pocket expenses. The fee is likely to be a barrier to the sickest, poorest patients who might avoid a doctor's visit because of the cost, get sicker and end up in hospital, requiring much more expensive treatment. Cash-strapped families might put off crucial immunisation visits for their infants. And please explain, how is a doctor meant to charge a nursing home patient who has no money? Former Health Department Chief Stephen Duckett recently told a Senate inquiry that the $7 fee, if it prompts people to avoid a doctor's visit and they go to a hospital emergency department, it could actually end up costing the health system more. It'll cost the government $31 if you see a GP, but $291 if you use a hospital emergency department for a GP-type visit. The CEO of the Garvan Institute, Andrew Giles, has pointed out another unexpected consequence of the fee. It's cutting donations to medical research. The government tried to put lipstick on a pig when it announced in the budget the savings from the $7 fee would go into a $20 billion medical research fund. However, several of the Garvan Institute's regular donors cancelled their contributions after the budget, claiming now the government's donating so heavily to the cause, they'll spend their money elsewhere. At this stage, the $7 fee is unlikely to get through the Senate, and Health Minister Peter Dutton is being forced to consider compromises. As health consumer groups who might want to have an input into any compromise on the new Medicare charges, it pays to know who you're dealing with. The new Health Minister, Peter Dutton, is a former Queensland cop who worked in the Sex Offenders and Drug Squads and the National Crime Authority. He also has some real business experience helping run the family childcare business where he employed 40 people. In light of our cow analogies on health ideology, it's worth noting Peter Dutton's mother grew up on a dairy farm. His website says he started his working life at age 12, delivering newspapers, mowing lawns, and fittingly for someone who would go on to work in Cabinet's razor gang, he worked as a butcher's boy. Dutton became a dragon slayer when he defeated the Democrats' defector Cheryl Curnow in 2001 when he was aged just 30. He got his first job in the ministry 3 years later as the Minister for Workforce Participation, became Assistant Treasurer in 2006 and served as Shadow Finance Minister before taking on the Shadow Health portfolio in 2008. With this kind of background, it's clear Dutton is the kind of minister that sees health not from a social perspective but from an economic perspective. In his maiden speech, Mr Dutton urged minimalist government intervention in people's lives. He voted with Tony Abbott to try and restrict access to the abortion pill, but told the National Press Club he won't try to ban abortions as health minister. And he's declared himself to be against nanny state policies that see the government try to tell people what they can eat or drink to improve their health. As someone who's been a health reporter for over 25 years, I think whether you're a supporter of a universal public health system or a private insurance model, the problems with our hybrid system can be boiled down to three main issues: access, affordability, and quality. Australia now has the 5th highest out-of-pocket expenses in the world, and they're about to get bigger thanks to the last 2 federal budgets. Around 1 in 7 Australians say they skip their medications or medical appointments because they can't afford them. 14,000 Australians raid their superannuation every year to pay for health care. When you hear ministers like Tanya Plibersek or Peter Dutton defending large cuts to health, it's frustrating to find they're always out to hit the hip pocket of patients or hospitals. There's plenty of abject waste in the health system that never gets tackled. For years we've been paying chemists $2 billion a year too much for generic medicines, while being unable to afford to put breakthrough new drugs on our medicine subsidy scheme. We've spent over $1 billion on a personally controlled e-health record that only a handful of doctors have signed up to use. So how do you as consumers cope with the yo-yo policy that ideology brings to health? The weaknesses of the latest policy change, as with Labor's policy changes, lies in their impact on real people. If you want to fight it, as your organisation says it does, then you need to personalise the impact of the policy. Use real people with real problems to show the true impact something that sounds good in theory has in the real world. Bring forward the Parkinson's disease and warfarin patients who need to see their doctor every week and get blood tests just as regularly to adjust the dose of their medicines, to show how for some people the $7 charge is not something they'll face twice a year, but twice a week. Find the patients who are waiting longer for elective surgery because more money has to be spent treating GP-type patients in hospital emergency departments. Bring forward the cancer patients who will pay $100 more for their PET scans as a result of the new fees. Make public the itemised medical accounts that show how the chronically ill have had their refunds from the Medicare safety net slashed. When for the first time in my 25 years career as a health journalist, I recently had an editor finally express a desire to run a campaign on rural health. I faced the same problem Kevin Rudd had when he had to combat the GST and he needed shovel-ready works projects. None of the rural health groups I contacted had a list of patients I could contact to tell their story. I had 2 pages to fill in this country's biggest selling Sunday newspaper week after week, and it was hard work. If you want to defeat ideology, you have to tease out its consequences, and the best way to do that is by using real people to make an issue come alive, get them to tell their stories about how an ideological policy impacts on their real lives. Thank you.
Excellent stuff. Thank you very much, Sue. And congratulations. I see in the Sunday telly yesterday that you actually got the New South Wales Government to review the patient transfer scheme and the benefits available under that in New South Wales. So that's a great outcome of the campaign on rural health that you've been running. Are there any questions for Sue? Burning questions in your mind?
I've got a little data question for you, Sue. Recently, I needed some neurosurgery, really neurosurgery with my spine. And I actually Googled the average out-of-pocket expenses, and the average out-of-pocket expenses for a neurosurgeon is said to be $49. I forked out $500 for the surgery and several hundred for consultations before and after. So I live in Adelaide, so there are limited options available. I don't quite understand in the private sector how I don't believe that $49 figure is accurate. So how do we get better data to bring forward those sorts of stories?
Well, part of the problem, I think, is the way they collect the figures. It's an issue that I've been very interested in for a number of years, and you can't crack it because the Private Health Insurance Advisory Council only collects figures by groups of item numbers, not by single item numbers. And it says that around 80% of services are provided gap-free. But when you go to a private hospital, you don't just have one service, you'll probably have about 10. So at least 2 or 3 of them are going to attract a charge, but that gets hidden in this global figure. And furthermore, it only captures the fees that you're charged while you're in a private hospital. It doesn't capture the figures of the $200 or $300 out-of-pocket expense you'll face every time you see your specialist. So the sad fact is that I think you have to get together patients to tell their stories by itemising their medical accounts. I did a story for the Sunday papers a couple of years ago about a cancer patient who had racked up $30,000 in out-of-pocket expenses for her breast cancer. That figure's now risen to $50,000. She is in a group some of whom have had $70,000 in out-of-pocket expenses. She sent me her itemised accounts, and that's how I was able to do the story. But a lot of it wasn't just what happened in the private hospital. Some of it was the expenses she faced outside the private hospital system. And the other way this material is collected is it's some information that's not publicly available. The government does collect data on the average fees charged by doctors per item number. It doesn't make that public. I've been trying to get hold of that for a number of months. I think the Senate Committee into Out-of-Pocket Expenses asked for some of that to be supplied, so hopefully we'll get an answer to that question which might shed some light on the subject.
There will be an opportunity at the end to ask further questions. Is there anything else burning in people's minds? No. All right. Excellent. We might move on to Michael Moore, CEO of the Public Health Association of Australia.
Thanks very much, Adam, and I'd also like to acknowledge the traditional owners of the land and pay my respects to their elders, past and present. Health is at a crossroads. Recently, the Treasurer, Joe Hockey, told the Sydney Institute, and I quote, "In health, it is more medical research combined with new technology and better global partnerships that will deliver better health outcomes." He's simply wrong. Or, in Sue Dunlevy's cow analogy, it's just bull. At the risk of taking a moment to preach to the converted, it is worth recognising there have been great advances in health through medical research and technology. And yes, they do play a very important part in our country's health. However, the greatest advances in health for all the community have come through prevention. And prevention has been most successful when government has been prepared to face issues squarely, to understand the extent to which health is socially determined, and invest in efforts to improve health across the community. And it does require government intervention. This approach is in direct contrast to the current reactionary political philosophy, which is spreading right across the developed world, not just Australia, with its emphasis on small government, favouring less intervention, and strengthening personal responsibility in all areas of government. Well, when I say all areas of government, other than defence and policing, of course. Following the discovery by the original epidemiologist John Snow and his colleague, the Reverend Henry Whitehead, of the link between drinking water and cholera, up until then people thought it was spread in the air, the British government embarked upon one of the greatest engineering feats of the 19th century. They retrofitted London with clean water and sanitation. With the non-interference attitudes of the current government, if they were dealing with cholera epidemics today, as was the case then, there's very little doubt that they would take appropriate action. Their solution would be a media campaign advocating boiling water and proper disposal of faeces. They certainly would not want to be identified as a nanny state, an attempt to regulate industry. That would have interfered with the Southwark and Vauxhall Waterworks Company, just because they were taking water from sewage polluted sections of the Thames and then distributing it. Why should government interfere with them? Actually, the campaign would probably work quite well for the upper echelons of society, who would have the staff at home to boil their water for them and also to dispose of their shit. Clean water and sanitation are basic to public health. We've just heard recently from a federal treasurer who thinks to be poor means not having a car. But much worse, a person in his position who doesn't understand the difference between regressive taxation and progressive taxation. And that's the problem we're dealing with, because it is so strongly ideological. Health is much more than just dealing with sickness. It's integrally involved in almost all aspects of government policy. On top of the other issues, we've just witnessed a federal budget that simply attacks public health and prevention. Some of the attacks are actually indirect or even unintended, but they will still have a profound impact. $8.2 billion has been pulled from the health budget. The Australian National Preventive Health Agency has been dismantled. The National Partnership Agreement on Preventive Health has suffered a death blow with the withdrawal of Commonwealth funds. Hospitals have lost their growth funds over the next 4 years. These actions are simply a process of cost shifting of responsibility to the states and territories. It's good for the federal budget, but actually we taxpayers are going to pay anyway. As I recently told the Public Health Association Immunisation Conference in Melbourne, the $7 co-payments will provide a disincentive, and Sue mentioned this as well, for young families and the less well-off in our community to go to their GPs for vaccinations. In New South Wales, 85% of vaccinations are conducted through general practice. Across the country, the average is 75%. It's actually much less in Victoria because they're conducted in a series of other ways, including through local councils. The AMA President, Brian Owler, provided a brilliant example of the repetitive costs to someone who has recently been prescribed warfarin. With the defunding of the Australian Medicare Local Alliance, the impending demise of the Medicare Locals, we wonder how the government intends to provide individual support, understanding, educational updates, resources for primary healthcare providers. They certainly seem a significant gap in program delivery at this point. There's also, as Sue mentioned, the $20 billion research fund. On budget night, in response to my own question, NGOs were informed that there was a deliberate decision that it be a medical fund rather than a health and medical fund, which does seem consistent with Joe Hockey's view of health as a business with the potential for financial return. There are challenges. Advocacy is needed. It's needed to improve understanding of the impacts of these cuts, to challenge reactionary and ideological thinking and short-term vision, to improve understanding of the drivers behind good health, and particularly the social determinants of health. And advocacy is needed to ensure health is part of all policies. In the most recent edition of the Australian-New Zealand Journal of Public Health, Professor Heather Yateman and I made the point, and I quote, "Most alarming was the process of creating significant policy change under the rubric of the generic budget process. This signals a major change in the political process in Australia, with potentially far-reaching impacts in public health." So we're gathered at this conference to improve our own understanding, but also to improve understanding of what is needed to drive better health outcomes. The conditions of society are fundamental. We need to look at prevention and primary health care as a comprehensive, integrated process, linking closely with the need for then further treatment. Advocacy work, capacity building, developing an understanding of the balance between personal responsibility, which is very important, and the responsibility of government, which is actually even more important, is the work of my own association, the Public Health Association of Australia, and it's the work of so many other organisations and individuals with whom we collaborate. This conference provides us with an opportunity to reflect, to consider how to be part of making a real difference in population health. I think together we can, we will, we must continue to improve health for all Australians and actually for people in our region as well.
Thank you very much, Michael. Any burning questions for Michael?
I totally agree with both speakers. I think one of the strategies, though, has to be the fact that the Australian electorate ends up electing these individuals who have a political, ideological philosophy that ends up creating the sorts of budgets that we've seen in recent years is the issue. So if we're going to be advocating, we need to actually expand the advocacy so it moves beyond within the health sector itself, but actually influencing the community, so the community has a good understanding of what the implications are, moving from a model of health and healthcare and social determinants to moving to a model where it's just business, and business has to give profits at the end of the day and has a totally different structure to talking about having a sense of community and responsibility for individuals within our community who have less resources and are not in a position to be able to access and maximise those resources that they have without the assistance and support of government.
This one?
Yeah, I just take that as a comment, I think, and I'm sure as a panel we can discuss those sorts of issues, which I agree are extraordinarily important.
Any other burning questions? No. Okay. We might move on to Di. And let's see if we can get the technology working.
This is because the last time I presented, I crashed the entire system when I tried to actually. I was simply too frightened to do it.
So did I.
Thank you very much.
I think we do that. So just
Yeah. Up and down. The last lady told me these two.
does the same thing.
Well, I'm just absolutely delighted to be here, and I'm amazed at just how many people I know. That's an unexpected pleasure, and I look forward to meeting everyone else. I've really enjoyed the frank and fearless discussions of our first two speakers, but I must warn you, I'm here as the chair of an organisation that will undergo not one but two tender processes in the next 12 months. One for a PHN and one for regional training providers, which have also been demolished in this budget or will be in the middle of next year. And I do know that we have a representative from the department who is involved in PHNs, and we also have some members of the press. So I'm going to endeavour to be exceedingly reserved and objective in my presentation. It is about PHNs, but it is, I hope, with a lens very much on patients, carers, consumers and communities, and how we have managed to engage with those groups now and how we might in the future. So what I thought I would try and cover very briefly is just the perspective that I'm speaking from about Medicare Locals in general, and then use Western Sydney Medicare Local, or Went West, as an example, purely because I know it best. There are a raft of wonderful examples around the countryside, and I'm sure if many of you are involved with your own local MLs, you've had experiences which are hopefully in balance very good. I've got a question right up the back at the minute.
What's PHN?
Okay, so Primary Health Network, which is the organisation that will be replacing Medicare Locals in July next year. The budget, this year's budget, forecast that all Medicare Locals would cease, or the funding would cease, in July next year, and there'd be a contestable tender process for much fewer and larger primary health networks to take their place. So anyhow, let's move on. So then I'll talk a little bit about the Medicare Local to PHN transition, as we are expecting it to be, and ask the question, are PHNs the same or different, or both? And what are the gains and what are the potential risks? I think that's important. And thirdly, I really want to ask this group, as I'd ask the New South Wales Consumer Health Forum, that we work with quite closely, can you be influential in shaping the way that process goes? So first of all, to Medicare Locals, and you're all aware that what they really are is primary health organisations. Most of the developed world has been trying to institute primary health organisations for a lot longer than we have done, over more than a decade. These are the objectives that the previous government provided to Medicare Locals, and just looking at those first two, which are labelled 1 and 1 for some technical glitch reason, you can see there's actually a lot of scope there for engaging with consumers and communities at local level, at regional level, in many different ways, even within those two objectives alone. And I know there are many wonderful examples of the population health planning processes that went on with very much in-depth local consultations. The problem with those objectives is that they are very generic and they allowed Medicare locals to either discharge their obligations very well or not so well, or to be confused and not know quite what they should do. So they've only been in place now at a maximum of 3 years. We were a first tranche Medicare local. We've now been in place for 3 years. Some have been in place for 2. They are young organisations, so the degree to which they've had time to mature and time to deliver is very limited. Nonetheless, because many grew out of divisions, overall the range of performance has been pretty good, and there's a very substantial number of Medicare locals who've actually delivered very well for their communities and given time would have continued to do much better. However, the lack of clarity in those objectives has been criticised, and the variability in performance even more so. There was an evaluation by Ernst & Young, commissioned by the last government, and it certainly pointed to excellent outcomes in many areas, but patchy performance overall. And the John Horvath review that was commissioned by this government said the same thing, which is why the budget justified its termination of all Medicare local funding and its transition to new organisations. Our view in Western Sydney that this is the fundamental role of Medicare, of a regional primary health care organisation, however it's called, is to lead, support and manage the transition of our fragmented, under-resourced, inefficient and inequitable primary health care sector into an integrated, cost-effective and equitable primary health care system, forming the foundations of a top-down, bottom-up health system. So this rather confusing drawing is the way I see what the health system should be, in that if we actually want to end up with empowered, supported patients, families, consumers and communities at the end of the day, we need to start off at the very top end of the system with in-depth consultation with the whole of our communities about what they value, what they think is most important, what choices they think should be made. It's not all about what the evidence says. It's not all about the advances in science and technology. It's very much about what we value. And I think our first 2 speakers spoke to that most eloquently. And out of that should come an agreed national health vision. We don't have that yet. An agreed national values policy and a key outcomes framework. We don't really have that either, or a national health strategy. What we did get in the last year or so of the previous government was a COAG, Primary Healthcare Strategic Framework, really important. For the first time in our history, we actually had a reasonable policy framework to take forward. And amazingly, that while it started life as a Commonwealth invention, it was ultimately signed off by the Commonwealth and all states and territories. And that led to bilateral state health plans. And when I read the state health plan for New South Wales, I thought, hallelujah, we're finally on the road. Even though we don't have the top end of that system in place yet, we have got this far, and that is a really big deal. And it wrote in things like Medicare locals and local health districts they are in New South Wales, working closely together to really serve the needs of their population and to create truly integrated healthcare. So, great start. Change of government and that framework disappeared from view. It was backburnered to such an extent it was impossible to tell whether it would ever again see the light of day. However, I'm pleased to see, I'm also on the Western Sydney Local Health District Board. We're just signing our service level agreement with the New South Wales Ministry of Health. It is full of the kind of language I love to hear and you would love to hear, and it has reinstated the bilateral health plan and the COAG primary healthcare strategic framework as issues of importance. So I think potentially we're back on the road, at least at state level. I don't know how it is in everyone else's state. And we have got in place the next consequence, or the next level down, which is the local health districts, the Medicare locals, the partnerships between those 2 organisations and a range of other players that go towards building a strong integrated primary healthcare sector and quality general practice. A long way to travel and a long way to go in terms of achieving equitable, accessible quality care, especially for those at risk. So that's my view of what a top-down, bottom-up health system should look like, building from the bottom, supporting it from the top. We've got bits and pieces in place. And what the Medicare Local LHD combination allowed us to do was to behave as if the rest of the system was already there. So now I'm going to just go to Wentwest, or Western Sydney Medicare Local, which is also the regional training provider for general practice training, the only organisation which has both functions, which allows us to adopt a really integrated approach to what we do. This came out of the National Healthcare and Hospitals Reform Report in 2008, and when I read this statement, I nearly jumped off my chair in sheer delight. It says, creating a better system to support a healthy start in life is complex because many of the key factors lie outside the health sector, including social, family, community and economic influences. Tackling the root causes requires new ways of working across health, education, family support and community development programs. I think that's brilliant, don't you? And then it went on to say, we acknowledge the need for such a comprehensive approach. Within this report, however, we focus on the health system. Damn it. Nonetheless, that was very much the attitude that we took forward in Western Sydney, and I think it was the attitude that was taken forward in many other areas. So we had a set of operating principles as a division that we took into Medicare Local land, and hopefully we will be successful in taking the same sort of principles through into a primary healthcare network. And I won't read through them, but I would hope, would find a degree of concordance with those principles. They were important to all of our staff, all of our GP supervisors and teachers, to convey the kind of organisation we were and what we believed in, to influence the decisions we made, but also to influence all the many stakeholders that we worked with, and to be incorporated into our partnership and collaboration agreements. So important. This was the partnership matrix that we developed very quickly with our local health district. On the left-hand side are the health service priorities, and beneath each of those there'll be a whole range of different programs. On the right are a series of enablers. No need to go into any detail, but just to give you one example, in child and family health, one of the programs in there is called Thrive at 5, where we work with a community which is immensely disadvantaged in Doonside, which is a suburb of Mount Druitt, and we work with the entire community to really help that community to understand the value of supporting and nurturing its children. We look at the Australian Education Development Index, not a health index, an education index. We work across all sectors to try so that when those kids, from the time, in fact from before they're born through to the time at which they go to school and have that AEDI calculated, we can bring those kids up to a level where they'll really benefit from their schooling, and their families are more capable of looking after their needs and nurturing them. So it's a very comprehensive program. The programs with the asterisk are marked only because each of those already has fairly well-developed consumer and community engagement in the whole decision-making process. Health Pathways, for example, is an area that takes a really important condition, brings together consumers, general practitioners, allied health and specialists from the hospital setting, and works to work out what are the best possible, most patient-centred, most effective pathways that we can develop for people to get them through the system with continuity of care in a patient-centred way. So patient-centredness, continuity, coordination, integration, very big deal. Okay, so thinking back to the objectives for Medicare Locals, we're now going forward to the objectives for PHNs. Now, these aren't actually fully developed. There were some very clear statements of what the Horvath report and the Ernst & Young evaluation reports thought those roles should be, and they were primarily around population health planning, commissioning of services rather than service delivery, and facilitation of integration, coordination, and so on, a much lower level of service provision. However, I've chosen to take 3 slides which come directly from the department, and I have great sympathy for the department at the minute, which is having to do an enormous amount of work in this area and in the area of RTPs in a ridiculously short time frame to try and work it out, the policy framework, and how they're going to take forward this tender process. So these 3 slides come from the department, and it's their best shot at this stage of what PHNs should do. They recognise the genuine need for an organisation at that regional level. They say the role of general practice is paramount, and I'm not going to argue with that, because if you don't, we have proven the fact, if you don't have GP leadership and engagement, you don't win in the end. A clear vision and purpose is critical, have to agree. Improved integration, increased leverage as facilitators and purchasers, all perfectly correct and proven by history. This is where it starts to bite. How many? We currently have 61 Medicare Locals. We don't know how many PHNs. It's somewhere between 20 and 30 at a max, maybe somewhere in the middle. That means a reduction of at the very least 50%, but better boundary alignment with LHNs or LHDs, which is a good thing, obviously, and clinically focused care integrators, all fine, except that a one-to-one relationship between a Medicare Local and an LHD is really an ideal arrangement. A 1-to-2 relationship is probably manageable, that is 1 PHN to 2 Medicare Locals. Any more than that, you really don't have a regional organisation in them anymore, and you really don't have good localisation processes. Clinical councils with a greater role for GPs, and a community voice through community advisory committees. Now, I'd say to you, a community advisory committee is fine, it's very nice, but it does not give you what I tried to show in the last slide, and that is multitudinous ways in which consumers and community are really engaged in the decision-making processes at every level of the organisation for all its activities. No community advisory committee can possibly compensate for that. So that's something for you to think about in your future advocacy. Regional purchasers of services, not providers. Outcomes-focused performance expectations, well, we'd love that, because we've for so long, like many other organisations, been rather programmatic and micromanaged. So outcomes-based focus with a good deal more flexibility on the hows would be fantastic. And maximising the investment in frontline services, all good stuff. So I think that's really the same sort of message. And again, there's really no problem with that at all. So what are the gains? I think we've already seen a lot of the gains in the Medicare Locals and the partnerships that have been developed. The ones that are perhaps additional to that is that we'll end up with Medicare Locals with more critical mass and more capability. And if they are commissioners, if it's the right kind of commissioning, they'll have a lot more leverage and capacity to manage change. That's probably a good thing. Better alignment of the boundaries, greater clarity. I think I've covered that. So at a very broad overview, that's the kind of advantages. But what about the risks? Too big is too big. And we're very fortunate in New South Wales in that we have a Minister for Health who has fought very hard to try and protect a one-to-one relationship, or at least to try and keep it to 1-to-2. So, and who's also very attuned to the gains that have been made in those partnerships. I have no idea what it's like in other states. In Victoria, I know you have a simply extraordinary number of hospital networks, something like 80 odd, compared to 17 or 15 in New South Wales, and similar sorts of numbers in other states. So I really have no idea how that's going to work. The other is perhaps this government, as people have mentioned before, is very focused on the money. And that means it will not just have a big focus on unscheduled hospital admissions and on reducing costs, but it may have an excessive focus in those areas. And it may, therefore, have much less interest in all of the kinds of programs that we have been doing that relate to equity, that relate to influencing the socio-economic determinants of health, that relate to accessing groups who have otherwise huge levels of disadvantage. And it may well be far less interested in engagement with consumer and communities and having those groups be truly able to influence decision making. Now, I don't know this, but I would suspect, given an observation of the environment, that's a real risk, and one where you might want to have a say. There's also a huge risk that has been openly flagged by the Minister for Health, and that is he wants this to be open to all sorts of players, and that means that there are numbers of for-profit organisations and numbers of private health insurers who, either alone or in combination, are looking at that PHN space. And I would have to ask you whether you think the role of a PHN, which seems to me to be very much an honest broker, trying to get the best possible deal for its community while getting the most cost-effective outcome for the funding agency, whether that should always be either a public authority or a statutory authority or a not-for-profit organisation, and whether it is appropriate for that role to be taken by a for-profit organisation of any ilk, or by, for that matter, for a private health insurer, or whether it's better for a PHN to be negotiating with all private health insurers to get the best deal. So finally, what might you do? I have the greatest of respect for Consumer Health Forum here and in New South Wales. I think the Health Voices is a magnificent publication, and I've had quite a lot to do with both levels of organisation. I've worked with Mark Metherell before, when pre this incarnation, and I know just how powerful his writing can be. He wrote a wonderful story about Health One in Mount Druitt. It's so wonderful that we laminated it and stuck it up everywhere. And I even have a copy in my house stuck up. So you have a power, and as Sue mentioned, you have the stories. And I think you have the logic on your side. So whatever policy positions you take, I would really suggest that you take them very publicly. The other thing that's quite extraordinary at the minute is that there's actually a high degree of coherence across the general practice state bodies. And UGPA, a truly ghastly name, United General Practice Australia, which is the RACGP, the AMA, the RDA and several others, are all actually singing pretty much the same tune here. And the AMA, I'm amazed to say, with its new president, is doing an absolutely excellent job of advocacy at the minute. So it may even be that there's an alliance to be had that goes across Consumers Health Forum, NCOS, a number of not-for-profit bodies, and the peak medical bodies, for the first time in history perhaps. I'll leave you with that thought.
Yes, the GP co-payment has certainly galvanised people who haven't necessarily been friends before, so it's an interesting space to be in health policy at the moment. Are there any burning questions for Di? Yes.
Thanks very much for that, Di. Just a quick observation. I think as consumers sitting in a room hearing all of the acronyms, you begin to understand how far removed consumers often feel from these processes that, to a great extent, control what happens for us out there in the real world when we're trying to get healthcare, and quite honestly kind of made my head explode when I was thinking about, all of the, frameworks, policies and all those other things, and the money that and work that went into the establishment of the Medicare Locals, only for them to be disassembled at what seems like a political whim to be replaced with something else is really quite sad. But I guess one of the things that came out of Horvath's report, probably the only positive thing, was, that emphasis on consumer involvement a strong emphasis on that in the new networks. And I would have to say that if we're going to be fair dinkum about this, we don't need to have consumers involved after they're established. They need to be involved in the selection of who actually gets the contracts. They need to be involved in the selection of who's the CEO of those organisations, who's sitting on the board, and all the rest of it. It's our money and it's our health, and we really need to get it right this time.
I don't disagree at all, but I would just say to you, the fact that the Horvath report said a Consumer Council, which is now being called a Consumer Advisory Committee, doesn't mean there's a commitment there at all. It depends very much on the way in which it's implemented. So I think that you have to have a high index of suspicion to get the outcomes that you're talking about. Is going to require a very definite position and very definite advocacy on your part.
Yeah.
All right, any other burning... Oh, there is.
Di, thanks for the talk. It's Diana Aspinall and I'm from Nepean Blue Mountains Medicare Local. As a director, I just want to let the people in the room know that we had $300,000 pulled from our budget immediately the budget was announced, and it was for consumer engagement. They just took that amount of money away. We do not have any money for consumer engagement or any resources to back it up, and yet we have a very, very viable consumer engagement program. And on top of that, we have a legal letter back from the department saying consumer engagement will not be considered.
I'll just comment on that. I think that Nepean Blue Mountains is one of those areas where the consumer engagement process has been absolutely outstanding.
My name is Betty Johnson. I'm from Health Consumers New South Wales, and I thank you very much, Di. This was what I was hoping to hear today, is somebody speak about this particular issue, because I see it as a threat to all of us if we don't do something about it. And the stuff that you said on page 3, suggesting that CHF and all of us get stuck into doing something now, I think if we don't, we'll be lost. The government will be able to ignore us. I know John Horvath, and I know John doesn't know anything about consumer groups, believe me. And I just think we've got to do something to show him what it means in terms of engaging consumers, where you find people, how, and leave it in the hands of people like Health Consumers Forum and others of us who are here to do something about this if we're going to be stuck with it. Because I don't think it's going to work. I think it'll work very nicely in terms of finding community people who are okay by the local doctors or the other health professionals around the place, and it'll be the health professionals running the whole thing without an opportunity for consumers to comment. Like we've had, we're winning that hard-won battle that I've been involved in for nearly 20 years. We've got a better recognition now than we've ever had, and to sit back and allow it to happen, I think it's against it. And I would like to we're allowed to move things here, is that we follow Di's recommendations and do something out of this conference.
That's why our board members are here. Absolutely. We've been talking to the department, involved in the discussions with them about PHNs, and we're in the process of putting together our response, I suppose, to what it is we've seen in the development phase. Yeah, absolutely. Yeah. It has been a very rushed process. Do you have any responses to that, Di? Did you want to? Couldn't possibly do better than that. All right. Any other questions we might leave for the end? And now I'll invite, or actually, can we thank Di? And I'll invite Noni up to.
Thank you for the opportunity to speak today. And the speakers before me, I guess, have talked a lot around the context, the environment, some of the key partnerships with Medicare Locals. And what I'm going to talk to you about today is, I guess, an example of what we've done as One Health Service in terms of consumer and community representation in a time of change. And the one thing that is quite evident is that the one constant is change, and how we work through that, how we maintain that consumer community representation. So just to give you a little bit of a sense of where I'm from Peninsula Health, which is one of the health networks in Victoria and covers the Frankston, Mornington Peninsula area. Population, around 340, but swells plus or minus with 100,000 in terms of tourists over the summer season, over the tourist season. Very high tourist area, very high in terms of aged care. Popular retirement place. So we know that the introduction of the National Quality and Safety Healthcare Standards certainly put community participation on the agenda for all health services, not just the national standards though, in terms of the accreditation framework that hospitals and health services have to follow, but it's been within the frameworks for a number of the other accreditation services also. So aged care, residential aged care, the Department of Human Services standards for community health, HAC programs, those sorts of things. But the national standards, certainly from a public health point of view, and from the private hospitals, very fairly and squarely said, all right, we need to have a look at community engagement. We have to have a look at consumer participation. Just for the Victorian context, much of the work in the area of community participation has come from the Department of Health's Doing It With Us Not For Us policy platform, a policy platform which, as you can see from the dates, has run its time but is currently undergoing evaluation to have a look at how we move forward, how we can learn from the lessons that we've had so far. As you can see, the focus on that meaningfully involved, meaningfully engaged is huge. It's a key. Not to preach to people who I think have clearly have a very good understanding around community participation and around types of participation, just to remind people though of the literature talking about the various levels of participation that we can have. So from that very basic level of providing information to people to help people make decisions, right through to consumer controlled entities and consumer controlled organisations. As well as the types of participation, we certainly can have levels of participation also. So again, starting with perhaps the Department of Health, working through the services, through the individual programs within those and down to the individual level, actually partnering in individual care. And I guess, what we know is that each of these require a different approach, but underlying all of them is that principle of mutually beneficial partnership. In Victoria, we have a legislative framework around community participation, so important to understand the legislative and policy drivers. We know, though, that they vary a lot through the jurisdictions. So how people, if people, and when people actually take up community engagement, actually take up that partnership, can vary across the states enormously. So we know in Victoria, community advisory committees have been legislated for a long time. So what have we done at Peninsula Health? We've tried to develop a really robust community participation framework, and I guess it aims again to have that mutually beneficial and that respectful partnership and that and the involvement and the engagement. So in what's quite a busy sort of a picture, it's around what we have tried to do is ensure there's very strong governance around what we do within the community participation area. And the part of that is ensuring there's very strong linkage through to the board of directors. The linkage occurs through the community advisory committee, but as has been talked about in one of the previous presentations, a community advisory committee on its own is not necessarily going to be able to enact change and not necessarily going to be do all of the things we need it to do. The other thing that we have in place is a designated executive director who has community participation under her brief as one of her portfolios. It means it doesn't fall off the agenda, and it means that it has to stay on the table all of the time. And I guess as we've continued to evolve and develop our community and consumer representative roles, we've had to evolve our governance as well. We've had to shift, and we've had to be ready to evolve and change and adapt to make sure that we're keeping up with what it is that actually benefits our staff and our organisation and our consumers as we work together within the health service. So one of the things that has been in Peninsula Health for quite a while now is a very extensive community network. So we have a community advisory committee, as we're legislated and mandated to do. But what we recognised is that what we needed was voices from throughout our community, and we needed those diverse voices so that we were able to have that engagement in service delivery and planning, engagement in what was important to the community. Were we meeting the needs of that community? And as you would have seen from that first slide, which showed you where Peninsula Health is, Peninsula Health surrounded on three sides, or the catchment's surrounded on three sides by water. Many of the people who work at Peninsula Health also live on the peninsula, a lot of vested interest. The community itself really in some ways don't have they have to go a fair way to actually, if they want to go past, to get to their health service and don't use Peninsula Health. So they have a vested interest in their health service. They want it to be the best that it can be. So the community advisory groups tend to be, some of them are service-based, some of them are geographically based, and some of them are around diverse groups within the population who have specific health needs that we need to try and address. The other part of it is around saying that participation, engagement and partnership has to be core to everything that we do. So we have about 130 plus consumer roles on committees within the organisation. Quality and safety committees, sub-board committees, and what we've said is that we need to have the right consumers on these committees. So there's quite a good process around recruitment to ensure that we've got a good fit. We also recognise that for many staff this is very new, and many of the staff, so we have to do work with the staff around how to work within this sort of a framework and context as well. But what we've said is this isn't might be nice to do, this is an expectation for all of the key committees that are set up within the organisation. And as we've moved forward and evolved, what we've been able to do is then have local quality committees at a ward level, at a program level, who are also inviting recent service users, people who've recently been through their service, to sit on their committees and actually be able to work in partnership with the program in terms of delivering better outcomes. So when we reflect on what we've been able to do over the last few years, we've got a strong foundation in participation and engagement. But I guess what we felt was that community participation alone is not enough, because what it won't do necessarily is improve and change the experience of the individual health user. So what we wanted to do was to move beyond that to saying we are a person-centred organisation and a leading person-centred organisation, that it's core to what we do. Partnerships are core through all of the levels, through all of the types that I talked about earlier. To do that requires transformational change. It's cultural change. And it's cultural change that we're trying to enact in the midst of what's already been described of the various uncertainties, the ever-decreasing budget and the ever-decreasing resources. So we can't ask people to work harder. People are working hard. But we do have to ask people to work smarter. And part of that is about key partnerships. Who do we need to partner with? We need to partner with our community and with our consumers. So what we've moved towards is a person-centred strategy that's giving us a roadmap towards becoming a person-centred organisation. But we've also said that has to align with the quality and clinical governance systems that we have. This isn't about doing something extra. This isn't about doing something new. It's about how we do things every day, and it's about embedding it in our everyday business, in everything that we do. a large part of it has to be on focusing on staff capacity and development. Unless we actually allow the caregivers and provide the caregivers with the support that they also need, it's very difficult for them to be able to partner adequately and provide the care that's required. So this just gives you an idea of what we've looked at in terms of the broader structures around moving forward towards person-centred care. Again, a really key focus on governance. What does that need to look like? How do you ensure that this is something that isn't going to just pass by, that isn't going to be changing when you've got changes within your senior management or changes within your board? How do we actually work with the staff? How do we work with the community? How do we work with the people who have been through our service recently, who can tell us the most about what it was like? And a big part of that, Sue talked about the patient stories, the patient narratives. I think that they are absolutely key. We need to make sure that the patient is in the room, that the client is in the room, that the carers are in the room every time we have discussions about the way our service is moving forward and about what we do and what we provide. And we need to be able to support staff to do this so that they can see it as not just being something extra, but also can recognise that it is a part of what they already do at the moment, because it's not suggesting that we don't currently provide person-centred care. We do, but we can do it better. So this just gives you a few ideas of some of the ways we've gone forward. In terms of some of the workshops, we've started very much with senior leadership, because we've said without the board, without the senior executive, without the CEO along with us and driving the change, there won't be a change. And that's what we're very fortunate to have been able to have. One of the key things being, as it said previously, so it is one of our goals within our strategic plan, and we debated long and hard whether you put it as a separate goal and pull it out almost as though it is something separate, or whether you embed it right through. The decision was that to start the transformational change, you probably do need to pull it out and put a spotlight on it, the concepts of person-centred care. So I'm not sure if you can read that up there, but goal one's person-centred care. So lots that we've achieved so far, but I guess still lots that we need to do as we move forward. So we've had the community advisory committees, we've had the community advisory groups for a while. I was very fortunate in 2012 to do a travelling fellowship, a Victorian travelling fellowship through the Victorian Quality Council, to go over to the States and have a look at some of the facilities and health services there that are doing practising person-centred care just as how they do business. They've turned their organisations around. So we will continue. Because I guess one of the risks is that we can make it a really formal process with no contact, with no relationship between the health provider and the consumer, except through really official mechanisms, except through our consumer feedback surveys and perhaps a couple of focus groups. But we need to make sure then, and we can then say participation's in place. Tick that box, we can pass the standards if we need to. But does it actually provide insight into each other's perspectives? Does it actually provide us with a way forward to change and to managing and dealing with the change that's occurring around us within the health sector? So we need that shared vision, we need the shared vision and we need the commitment. And I guess we need to know that, we're not always sure how it's going to look, and we're not always sure how it's going to work out. And that's the leap of faith. That's what needs to be taken in this space also. There's no right way and there's no right time. And I think we can wait and wait for the perfect storm, and it's not going to come. There is constant change. There's lots of things we can do, and we can do straight away. And start where we've got traction, start where we can have those get the low-hanging fruit and have the successes. Otherwise, I think we keep waiting. Don't reinvent the wheel. There's an enormous amount in the literature. There's an enormous amount around the health services, around this tables. The tables here, the expertise is enormous. We need to use that. We need to share that, and we need to be able to have mechanisms to allow that to happen. So, and I think looking within your own organisations, within your own health services, in my example, there's good examples there. There's fantastic work being done. Sometimes it's hidden away in a pocket that nobody knows about it. The other big thing is, I think, this concept of how long transformational change takes. So having said we have to act now, this is part of the reason we need to. Transformational change takes time. We've done, I think, within the health services particularly, a lot of the false start project mentality. And that's probably necessary and it's a good foundation. But to keep moving forward, to get that absolute integration and strategic alignment does take time. And I think it's also then about ensuring that boards, executives, I guess, in a time where we can have a 3-year turnaround in terms of the health cycle from, in line with politically what's happening, we need to have a strong commitment to hold out for that long. There's a whole lot of expectation that transformational change will happen in 1 year. We know that it won't. And I guess that, for us, the big thing has always been to always focus on the consumer, bring the consumer into the room, and and take advantage of the strong partnerships. We have an enormous amount to learn together. I don't think that, I think it isn't an us and them, and I think it is about partnership, and I think it's about recognising, valuing and acknowledging the expertise that everybody brings to the table. Thank you.
Any burning questions for Noni? Dan.
I pay a lot of attention to your presentation and your organisation charts and so forth, and I can't comment about Peninsula Health, but I can certainly comment about a few other major metropolitan Melburnian health services. And on paper and on organisation charts and on mission statements, they tick all the boxes, but God help you if you're ever a patient at any of these places. And what I was interested to know is whether you have at Peninsula Health a real interface between your consumer advisory groups and the whole complaint process should a complaint find its way to the hospital, whether directly or through a care complaints forum. Because there's actually a rich seam of valuable patient stories to mine there, and they are being buried, those stories, time and time again. And I go to all sorts of wonderful workshops, conferences, etc., how to improve hospitals and this, that and the other. And the voice that's ignored 99.9% of the time is the real patient experience.
Yeah. Absolutely, I think that's really true. And I guess, so there's two parts to it I'd answer. One is I think we do need to use the stories. So we made a DVD of 3 patient experiences. They were very poor experiences. And so we made a DVD of these experiences. A lot of debate again about whether you do the good, only the good, only the bad, where do you go? Do you do a mix? In this instance, we did what were the bad experiences. And so we use that within orientation, we use that within our staff education, and we use that as one of the means of getting the stories, to the frontline staff particularly. We've also, I think, trying and moving more and more towards trying to actually gather some of these stories, have some of these stories together. So we do use also complaint letters as a part of orientation. Any of the workshops that we've done in terms of working through our person-centred strategy have been developed and put together in partnership with consumers who have presented on the day and have been telling their stories. We've had a lot of assistance from Health Issues Centre who have been doing training for consumers in how to tell your story, because that's not easy by any means. That's, this is very emotive, very close stuff for people. But it also is important that the way the stories are told actually then gets a key message across and gets some meaning across. So that's been part of it. Just recently we have started to have a look at how we can have a greater involvement from our consumer representatives within the complaints process, and in looking at what our complaints are, understanding the trends, understanding some of the things that we need to do differently. And I guess that's where we felt what's needed very much is that individual level. The recent service users, the people who've been through our services, who can actually bring that richness.
Fantastic.
I even have, would you believe, another issue, and that is the whole issue of what hospital board directors are really hearing about what's going on in their hospitals. Dr. Marie Bismarck at Melbourne University School of Population Health last year had a journal article published in the EMJ, Journal of Quality and Safety. She interviewed every single hospital director in Victoria, and quite a few of them said, we don't know about a problem in our hospital until we read about it in the Herald Sun. So that's a terrible indictment of what's going on in the hospitals.
Absolutely. Yeah. All right, can we put our hands together for Noni? Thanks very much. And can I invite Laura up?
Might be able to see me. Thank you very much. I'd just also like to pay my respects to the traditional owners of the land we're meeting on today, and also extend my respect to all of the Kulin Nation elders, past and present. I'm a Koori woman, but I live and work in Western Australia, so I'm a long way from home, and I work for the Health Consumers Council. We're a peak body for consumers in WA, and we have our acting executive director, Martin Whiteley, one of our advocates that provides assistance to consumers with a query, a problem or a complaint related to any health service in WA. And also one of our board members, Tom Benson, here today as well. I manage our Aboriginal Advocacy program, which has been going, and I've been there for 8 years now, which is a mixture of providing individual advocacy assistance, again, to consumers who have problems or are kind of lost, perhaps don't even have access to a service, is possibly a lot of what I deal with. But also we look at how to address those issues systemically, and I think that's been of paramount importance, because I think sometimes when people do have really bad problems with a health service, they have no faith that actually making a complaint would make any difference to their concerns. And I think sometimes when people already feel that, it can be quite humiliating to even try. But we support people to do that as much as we can without pressuring them. I think as well in smaller towns, the implications of not really being sure how a complaint will be addressed has a lot more rebound effect in your life. You know, your kids probably go to school together. There's not much anonymity, and I think that really impacts how people feel about talking about problems. And another part of our program's role is to increase... Sorry, I'm trying to slow down because I usually talk too fast. Tell me if I do. To increase Aboriginal consumer voices in mainstream service delivery in WA, and that in itself's been tricky and a big process, and I'm going to come back to that a little bit later. What I did want to focus about in talking about a changing environment in health is the Close the Gap campaign, something that started back in 2006, or was launched in 2006, between quite a large alliance of a lot of our peak bodies. I think the most significant of which to mention is the National Aboriginal Community Controlled Health Organisation, and I think it's really fantastic that the policy officer's here with us for the next couple of days as well. It was then adapted, I guess, by the federal government, or certain commitments were in 2008, and that involved a lot of national health partnership agreements that were also across other areas of housing and education and things that we recognise the importance of, you know, I guess the very basis of having good health. Then that initiated a 4-year funding cycle, the initial, I should say, 4-year funding cycle, at the end of which we had a pending federal election, and even though Closing the Gap is about targets between now and 2030 and actually closing woeful disparities of life expectancy and also health expectancy between Aboriginal Torres Strait Islander people and the rest of other Australians, the funding was only extended for 12 months, and I think I can tell you what's happening in WA at the moment, but I'm still quite confused about what's even been committed to around the rest of the country. So whilst it's enjoyed bipartisan support and platforms, in terms of how that affects things practically, there's been a lot of chaos in the last few months, I think, for staff that didn't know whether they were going to have a job a few months later, and I guess that lack of commitment impacts community sort of faith in the latest new program. I found as a younger Aboriginal person, sometimes I think the consumers I work with will be really pleased about new initiatives, and I often find that they've heard it all before and they've seen it come and be taken away again before. So I think that we lose a lot of the traction that we've sort of established every time there is that kind of uncertainty. I think for us as well, it sounds that all of our Medicare Locals outside of the metropolitan area in Perth are going to be amalgamated into one primary healthcare network. So that would kind of be like asking people in Geelong and Cairns to start making your local health planning together. When it's based on population, I think sometimes it doesn't meet the need. A little WA whinge there. I think one thing to point out about closing the gap is that in a way it's atrociously sad that we need to do it. It's atrociously sad that Aboriginal people, First Nation people of this country have the kind of health stats and expectations that they currently do. It's also really sad that we needed to make a jump up and down campaign to actually draw attention to that and get some kind of significant funding and partnership commitments to that. And I think it's sometimes we don't represent enough of the population to warrant notable data and things that we commonly rely on for those kinds of decisions. But in a way, I just want to point out that the message to Aboriginal consumers is incredibly depressing. Hello, you're dying younger than us. Hello, you're not getting the same outcomes. I don't think we've even begun to speak to the people who we really need to be targeting in those messages, because I do work with a lot of vulnerable and kind of despairing consumers who are quite resigned to the idea that they're going to die younger than other people and that they should expect to kind of have worse health experiences and outcomes. So even though a lot of the programs that have actually been funded under this, I think, are doing really great work, it's those messages of strength and I think remembering that we're talking about people and at the end of the day, in a way. But so I think coming back to kind of the gaps in Aboriginal voices in mainstream health service delivery, I just wanted to kind of talk about what some of the barriers are, but how broad, I guess, I think the spectrum is. Because on the one hand, we work with people that have barriers, and this is to both accessing health services, but I think to also accessing consumer opportunities to have input, that have barriers either because, could be all of the above. It could be language, and English might be your third or fourth language, not just your second. Geography, of course. If health services you need are 2,000 kilometres away from home, away from family, away from country, Aboriginal people that are lucky enough to live on country want to be on country when they're unwell, want to be on country when they're dying, and want to be on country when they're having their babies. And for a lot of them, that's not actually possible. And I guess I also work with a lot of people that choose to stay on country and not come and get health treatment away from home, as their way of dealing with that. I guess it's quite sad. Poverty is another big reason. But speaking up to non-Aboriginal people, I find it that often the same people I'm working in with meetings and that I've known for years, I then take to another meeting with some non-Aboriginal managers of the service, and most of whom have been great, and worked really well with us, but found the same people are incredibly shy and almost kind of shut down. So I want to acknowledge that it is kind of a different sphere. As, again, First Nation peoples that have also been colonised, we still have a history that I don't think is as distant as people often consider it to be. Like, I'm in my late 30s now, and I'm the first generation in my own family to be born with human and civic rights in this country. And the impacts of that, I also didn't actually grow up with my own mother, so I didn't escape entirely some of the impacts of a lot of past policies. But I see a lot of the barriers my mother has to accessing services because of a lack of trust, and because that was associated with things like taking the children away. Not always and not for everyone, but in our experience it certainly was. Trusting people and opening up at all, particularly any, I guess, health encounter does have quite a power imbalance kind of going on. It just can be really difficult for people. Something I really don't understand is why when we have one-on-one interactions with health practitioners, not enough of them seem to actually ask what our understanding of what's going on is. So I've worked with people that have been swapping heart medication with different conditions when they couldn't afford to buy their own, thinking that they're doing the right thing. I worked with a lady who had stopped attending renal dialysis appointments when she was given a new tablet because she didn't understand that without a transplant she would be on that machine forever. And she had been getting dialysis for a while. To me, there was quite a long time and a lot of opportunities. I couldn't believe that she didn't really understand that and that no one had made sure of what her understanding kind of was. And I just think sometimes we're really too busy to check a lot of those things. But even when it comes down, I guess, to patient compliance with medication, it's critical. Like, patients are actually a part of the health team. I don't really need to tell you that, I'm sure, but this is often what we deal with. I worked with a young mum who went to her local country hospital, and a lot of people do, particularly if they're in a town without an Aboriginal medical service. Often the hospital's the only place you can go if you don't have money to see someone, and in other cases is the only place anyone can go in your town. But her child had a wound around her eye, and she kept representing, over a period of about 6 weeks. And towards the end of that, one of the nurses wanted to take her 2-year-old aside to speak to them on their own because they were concerned that it was abuse, basically, even though if she checked the notes, she would have seen mum had been in 6 times and still not really got the help she needed. It actually turned out to be leukemia, and, she lived 2,000 kilometres away from where the treatment that they needed was. So fortunately, their little one has had a lot of treatment and is back home now. But I just mean racism and stereotyping is a real thing, and sometimes for any of us, I think when you have a sick child that you're worried for, you're not really at your best when you're begging someone for help and you don't seem to be getting it. So a lot of our mob might sort of lose their temper instead of knowing how to articulate themselves calmly through that, and often actually get us to leave the hospital without anyone figuring out what's even going on. I just think that it's not always aggression we see in hospitals, it's often anxiety and distress, and that we should learn the difference and I guess how to help people through. But on the other hand, we have an Aboriginal community-controlled health sector we established our own sector 40 odd years ago, and it's still, I think, the place where you find the most success stories, the expertise and the knowledge about delivering services to our own people. If you don't know, the basic model of most Aboriginal medical services means that you will get access to a free access to seeing a GP with health screening by an Aboriginal health worker, very opportunistic and thorough screening. They're good at making opportunity of the fact that you're there and that they're not chasing you up later. And I even find that, like a lot of the country town folk that I work with don't have postal delivery services. A lot of them still aren't using the internet that I work with. And I think a lot of the consumers I'm privileged to work with were the first Aboriginal nurses in their communities, and they're still real health leaders in both their family and kind of community. A lot of Aboriginal medical services provide quite a range of other social and emotional wellbeing and holistic care, and have just become a hub, I think, for all things kind of... I think that they have a much higher level of ownership for all of their patients. If you don't know as well, like any Aboriginal person can be a member of their own Aboriginal medical service and they elect their directors. So it always comes from the membership, and the whole membership has the opportunity to have input in that. And I'm not aware that any other health service in the country is community controlled in that degree, but I'm interested to know if anyone does know of any other area. But also, Aboriginal consumers have incredibly high expectations of their Aboriginal medical services, often quite a bit higher than how they expect to be treated by other health services, and they will definitely let you know if there's a problem with any aspect of that service. But I just think we need to, I guess, recognise the success of that partnership model. It's often the same biomedical model that we're kind of working in, but it's kind of done our way. And I think that the data can tell us which organ failed and really other critical information, but it doesn't always tell us why somebody didn't access the service, or whether they tried and got turned away, or kind of why we're, a pretty critical part, I think, of why we're having much worse experiences than other Australians. And I guess I'm trying to make the point you can't generalise about all Aboriginal people. I think we have people that are so empowered, they're running their own health sector. We have over 150 Aboriginal medical services around Australia, and I guess they managed to do it on a lower budget than sort of most services, and to get really, really good outcomes. I'm pretty sure that the sector's already said that they would not pass on a $7 payment to any of their consumers, which of course means that the sector will be paying for it itself, and they often already struggle to compete with the kind of prices that even our hospitals have to employ doctors. It is quite a market out there, and if you're not running on a profit model, then it's very difficult to compete. Also, the National Aboriginal and Torres Strait Islander Health Plan, I just wanted to mention, there's a blueprint for how we might, by 2030, not need someone like me to come out and point these things out at our functions. But my final point is just about working together and working with us, and not expecting Aboriginal people to come to your table. It's recognising we've already got our own sector. I don't just mean the health sector. I mean, you look at... I work with people often that say, well, we can't get Aboriginal people to come over here, but sometimes there's an Aboriginal organisation across the road and there seem to be a lot of people there. I think we have to cross the road. That's kind of what I'm saying. Thank you.
Thanks very much. Burning questions for Laura or questions for the rest of the panel is now the point that we're at. So I think we've got a question...
Yeah, the computer system.
I think people in the sector could talk about it better, but things like the ferret system existed for a lot of Aboriginal medical services within WA, and that was a lot of opportunistic screening. So if if Doris comes in today, it might tell you that her grandkids were going to have to come in for an immunisation 2 weeks later, and they live 200 kilometres away from the service. So things that would flag extra stuff that would create those opportunities, knowing that people might not be able to come back in around again. I know that in the trials of MMEX there's been a lot of issues around patient confidentiality in terms of other services being able to access stuff without patient permission. So I know there's been a lot of teething issues, but I mean, I think it is critical that we can communicate better with other services, and that is sometimes what we deal with as well, is patients whose results never got to them, and sometimes they were woefully ill, and if those results were there, they would have had an opportunity to get treatment that they've now lost. So, yeah.
Can you just explain to us what MMEX is? It an acronym for something?
Sorry,
or?
it's about sharing patient information and electronically.
Right.
Yeah, so it was part of the preparedness, I guess, for some of the other stuff. The patient electronic health records are kind of aiming at as well. Yeah, you find a lot of the earliest trials of that stuff has been sort of between the Northern Territory and the Kimberley.
Yeah, I can do it.
Oh, Health Foundation.
Oh,
Health Foundation.
okay. Are there any other questions at all for the... I think we've got a question up the back here and then one down the front.
My name is John Lewis. I'm here for Monash Community Health, and also, although Parkinson's don't know it, I'm here for them too. That's because both my wife and I have got Parkinson. I think there's areas like motor, excuse me, it's motor, please. I'm sorry, it happens like this. Well, I live in a hostel, or we live in a hostel, of which there are 130 people and 19 of them have Parkinson, which is a pretty high percentage. But they are all elderly people, of course. Mm-hmm. We don't seem to look at these boutique diseases like Parkinson and motor neuron disease and multiple sclerosis. It harks back, the way I think, it harks back to nursing. Now, on the curriculum of nursing, any of the ladies that are nurses or carers at our hostel never taught anything about multiple sclerosis or Parkinson. Now, I think that we've got a great army out there of people like me who can talk about your disease, and it gets through much better to the people that you're talking to, because they know that they're talking to someone that, because of their experience, they will know something about it. And I think that we should go out, the community health people should go out and try and get people from their areas to come and talk about it. And the other thing is that the talks that I've given to the hostel I'm in, none of the girls there had ever been taught anything about Parkinson. And where this shows up is if you go to hospital with Parkinson, whether it be private or public, you can never get your tablets on time. And it's very important for people with these kind of diseases to get their tablets on time, otherwise you go downhill. And you can't get through to the hospitals, especially the public hospitals, you cannot get through to them that the tablets have to be taken on time. It's not good enough to say we only give them out at 3 o'clock and 6 o'clock and 2 o'clock in the morning. It doesn't work that way, because if you start getting too big a gap between your Parkinson tablets, you're in trouble. And the only person that gets into trouble is the person with the problem. So I'm just suggesting that we somehow get it into the curriculum of nursing, talking about these boutique diseases, because the great unwashed out there simply don't know anything about it. I'm sorry I took so long, but...
Does anyone have any response to that one? All right, any other questions for the panel? Over here. Oh, I think this gentleman down here first and then over there.
Yeah, I'd like to commend all the speakers. I think it's been great. The information that we've received has been brilliant, and I think those of us that are trying to help provide services will get a great deal out of it. But in particular, I'd like to address my question to Dr O'Halloran, but other speakers might well come in it. Doctor, much of what you've been talking about in the Medicare locals and the transition will require legislation. Not all of it, but some of it will. Correspondingly, each of the states will probably require matching legislation, and I'm just concerned that this could be a lengthy delay in getting agreement with all states, bearing in mind that in South Australia in particular, the current government doesn't have the majority in the upper house, and this could create some issues. So I'm just wondering whether you're picking up a feeling for that. Now, I chair the Country Health SA Local Health Network Governing Council, which is all of country South Australia, but we liaise with all of our 5 Medicare locals because they all touch on the fringes of the metropolitan area. So we've got an input all the way around, but the Minister of the Day, it's just gone flat, the Minister of the Day is reluctant to bring amending legislation into the Parliament. He'll do anything by regulation, but knowing full well that he may not get it through the upper house.
I'm actually not aware of there being legislation required for this transition. So I think that delay is unlikely. I mean, the main problem at the minute is the speed of the whole process going forward without legislation of any kind being required, which is why it's actually so tough on the department, trying very hard to develop some policy and some order in the whole process. Really, that they are expecting a complete rollover by the middle of next year. So unless you're aware of the legislation, I don't think it is required.
I'm Judith Ma and a member of Consumer Health Forum, and I've been a consumer rep for going on 14, 15 years now. Mine is a very general observation of the situation between consumer groups and the present government. Number one, I think this government appears to be selective in its advice seeking. It will select whose advice it wants to listen to. Number two, this government doesn't abide criticism from organisations to which it provides money. It intimidates organisations into timidity. And three, because CHF and other consumer groups over years have been voluble in their criticisms of health policy at all levels and with several governments, in my view, CHF and other groups are seen by this government to be in opposition to it. CHF is designated as anti-government, and so government deliberately closes its channels to it and reduces funds to some organisations, as we've heard, without notice if it feels offended. Consumer groups are viewed by an ideologically driven government, are viewed as Labor supporting organisations. And to my mind, this is the background against which consumer groups must work now and into the foreseeable future. And I'm quite happy to have my mind changed while I'm here.
Well, I think the tenor of your comments picks up on some of the tenor of the presentations.
I'm happy to make some comments. We face this with the Public Health Association as well, which is considered by quite a number of governments to be somewhat to the left of centre. I think we have a fundamental responsibility to work within with whoever is in government. And in some ways, it was probably easier working with the Labor government because of less ideological differences. But in the end, ministers are actually trying to get better health outcomes. They live within an environment that I spoke about, and that is very challenging for us. Will they cut funding? Well, that's quite possible. They're going to pull $200 million over 4 years out of one of the funds that most organisations have funding from. So I think there are challenges. I don't know that they're actually particularly attacking individual ones, with a couple of really notable exceptions. You know, the Alcohol and Drug Council of Australia was a clear ideological attack driven by, we don't know for a fact, but it does appear to be driven by industry. But it still comes back to fundamental. Yes, we can go, oh dear, we're offside with government, or we can say, actually, we've got a responsibility. The people have elected these governments, and that's who we have to work with. And I think that that makes, in some ways, it makes our job much harder. But it also makes the alliances for us working with Consumer Health Forum, Health Promotion Association, Faculty of Public Health Medicine, and so on, much more important, so that we can deliver for better health outcomes, which is what we're really all on about.
Thank you. I wouldn't disagree with you, but I think one thing that we all have in common is that we have an obligation to advance the evidence. And I think that this has been pointed out many times this morning, that the evidence is actually really strong about a number of issues this government would appear to be unaware of. And it's our, in a sense, our obligation and our duty to put it forward, and that relates to patient or person-centred care. It relates to the whole of the primary healthcare sector as the essential foundations of the health system. It relates to the benefits in terms of better population health outcomes at lower costs of no barriers to good primary health care. I mean, the evidence for a cost signal reducing costs is pretty poor and pales into insignificance compared to the evidence for unfettered access and what benefits that's delivered. So I think we've got to be stronger on mutually advancing the power of the evidence around the issues that we care about.
I also think it takes us back to Sue's point, which is the power of the story is actually what's going to win this argument. We can talk, and I've said this in a number of forums recently, we can talk about the millions and the billions, and we can talk about the hundreds and thousands, and we can talk about the thousands of people with a particular problem, but behind every one of those numbers is a person, and it's that person's story that's going to help Sue get a front page, that's going to help millions of people in New South Wales see Sue's front page and pressure the people that need to be pressured to take note of those particular issues. Yes, I agree that there is less of an interest in representative organisations, and that's not just in health either. But the power of the story, which is where all of you are so valuable, is what's going to win us through.
But the story has to be based on sensible evidence.
Yes.
Then it makes sense.
Yeah, one more.
Hi, Brinny Goodwill from Sydney North Shore and Beaches Medicare Local. I'd love to follow up on so many things that were said this morning. But I have a question for Noni, because you've mentioned that you are very involved and interested in partnerships, and what I'm interested in knowing is what now currently Peninsula Group is doing with your own Medicare Local and Local Health District, and how you see that relating to the primary health networks that are being proposed. Because as many of you may know, the population health needs that the Medicare Locals have been doing are just astonishingly detailed and terrific pockets of sources of information about how to respond to community needs in a very profound way, which is a very different kind of role than a health provider, what a health provider does and has, which is much more responsive rather than proactive as the Medicare Locals are. So one is, what are you currently doing now? For example, responding to some of what Laura is saying, in Sydney we know where pockets in our district are that are dealing with Aboriginal health, or where the health needs are not being met, and are looking very specifically how to address that. So how are you working right now with Medicare Locals and Local Health District? How do you see the primary health networks as supporting better health outcomes, and how do you see yourselves, I don't know, perhaps even looking to have a very significant role in that type of establishment?
So I think for Peninsula Health particularly, you know, as you saw the, you know, almost the geography of where we're set as a health service, we are the public health service in that area. We do have then the Frankston, Mornington, Peninsula Medicare Local. And what's been established is what's described as a Peninsula model, which is very much around that partnership with the Medicare Local, with the other key primary care providers in the area. And it's through the Peninsula model that we'll be able to move forward and work with the changes that will happen in terms of the primary health networks also. From within the Peninsula model, then has been the identification of, as is many of the other Medicare Locals, the health alliances, and based on the population health, based on the demographic, based on the work that's been done around identifying need in that peninsula, in the catchment. And certainly Peninsula Health's had a very key role in terms of representation, driving, working with the Medicare Local, working within the Peninsula model along those lines.